Okay, so our first speaker is Dr. Joshua Zaritsky.
Okay. So the question is, what is the optimal approach to successful transition of older adolescents, young adults in, if they've received a kidney? What is the ultimate model? We have no long-term data. I can tell you that we're not doing a great job, but I don't have any data to show you which model is better than itself. So it's an area that's primed for research, and it's an area that, we should all be concerned about. So what are some of the barriers to transition? One of them is just the simple thing is if I just, if you said, hey, Dr. Zaritsky, you're seeing this adult doctor, go see another doctor tomorrow. That's a difficult transition in itself. And I'm, although people might disagree, I am an adult, I'm mature. But that's a difficult transition for me. I have to go get to know someone. So you can imagine for an older adolescent who they've already have a relationship with a doctor to go kind of reestablish that. Then there's also this idea that the parents, right, they have to somehow, especially when they go to an adult doctor, relinquish some of that control, right? Now all of a sudden that, the parent isn't necessarily welcome in the room, right? That patient's over 18, that person's supposed to be making all their healthcare decisions. There's the problem with us saying, hey, I'm going to hang on until the very end with these patients, right? I have a relationship with them. I've taken them from birth through transplant, and I just don't want to let go. So I'm going to wait to that very last minute at age 21 where I have to send them away. And then I think the biggest problem is this idea of the availability, familiarity of adult healthcare professionals to assume responsibility for care. And you look at a lot of the time, and I'm going to show you some slides, but some of the diseases I treat, X-linked hypophosphatemic rickets, cystinosis, these are extremely, extremely rare diseases, right? So to me, to send to an adult provider a patient with cystinosis, they might as well send me a patient who has just had a heart attack, a 75-year-old person who's just had a heart attack. And I'll sit there, I'm thinking back to medical school, Mona, morphine, oxygen, I don't even remember what the N is in aspirin, It's just not fair. It's just not and it's not a good model to provide health care. So, and so if you look across the spectrum, I don't even have to talk about CKD per se, but look about some other diseases. So in some sense, we are a victim of our own success. That if you look at the changes that we've been able to, so childhood cancer used to be a disease that everybody died from. Now look at the survival rates. Look at cystic fibrosis. I'll show you some more data on that. Congenital heart disease, right? These are diseases here that patients used to die from in childhood. Now they are living into adulthood, which is great. But who's taking care of them then? Who's taking care of them? So the old model, pediatrics into adult, meanwhile our medicine has changed, our ability to provide care has changed. Where are we with that? So if you look at cystic fibrosis survival, right, look where people are living now, right? So who's taking care of these patients now? Who are the docs that are going to be willing to take on this burden take these patients on? And one of the diseases I take care of is cystinosis. So maybe there's about 500 to 600 families affected by cystinosis in the country. It's a chronic disease. What we've noticed is that since we've had renal transplants, since we've had some therapies that have come along, right, we've had to change the natural history of the disease. These patients used to die from renal failure in this age group, right? Now, thanks to technology, better understanding of the disease, cysteine depleting therapy, they're living on. So I don't know, as the natural history, we see pancreas problems, we see a lot of other problems. Who is willing to take on these patients? And you see these, if you go to a cystinosis family conference, you run into adults, they say, I don't have anybody who's willing to take care of me. The adult model is different than pediatrics. So you can imagine adding that problem onto transition. Some of it has to do with culture of care, right? So if you look at the culture of care of a pediatric provider, it's typically very family-centered, right? We have a family member who's providing care. It's developmentally oriented, right? We spend a lot of time on school, life progress. There's a high level of psychosocial support. I couldn't do my job without my psychologist or my social worker. It's very interdisciplinarian. It involves parent direction and consent. I'm a partner with the parent. It's flexible. You would think maybe this is the best way to care for patients, right? But it's very, very resource intensive, and it doesn't work for everybody. If you look at the adult provider, right, here now we're individually based care, right? I go see the doctor. My mom isn't there. I know she'd like to be there, but she's not. So it's disease-focused, right? You're there to be talked about a disease. It's a very cognitive approach, right? And especially a lot of times we want that, with we expect the patient to be cognitively there appropriately. It's multidisciplinary rather than interdisciplinary, and it requires the patient to be autonomous and function independently. That is the biggest thing. So that's a very difficult transition from one culture to the other. So one of the things that always comes up when I transition to CKD care is this idea, or any pediatric patient, is that as pediatricians, we've babied our patients. And this was for, I think, the last 15 years. This has been the major focus on us in pediatrics, that we're too kind to our patients. So, for example, if my patient doesn't show up to a PD clinic, we're on the phone. Hey, why didn't you show up? If the pre-transplant patient doesn't come to clinic, we're calling them. Why didn't you show up? Right? And you can imagine the adult care. Well, listen, your patient doesn't show up. You have 50 other patients to see. You can't afford to call. You expect them to show up. And so maybe some of the transition problem is just due to the care that we provide, that we baby them too much, and that we need to be tougher. And so there's some models out there where, like at age 13, we want them to do, have their own medication list. We want them to start scheduling their own appointments eventually. We want them to have an appointment alone with the parents. Well, that's fine and good if you assume that there's normal neurocognitive development for these patients. That at 18, you've lived a life with CKD, that you are neurocognitively the same as an 18-year-old who just walks off the street. And what we recognize now, that is simply not true. That's simply not true. So, and there's more and more data to support this. So we have a large collaborative now called CKID, which is basically looking at the natural history of chronic kidney disease in patients. When they looked at this group who had mild to moderate CKD, this wasn't just patients on dialysis. They looked and did performance testing. They found that 35% had poor performance, at least 1.5 standard deviations before the norm when you look carefully at these patients. And you can see it's not just, language might be okay. This is from another study. But if you look at verbal memory, and especially executive function, one of those things that you say, hey, tomorrow I want you to drive across the street to, Christiana. Their executive function is not completely normal, right? And we need to now follow these patients over time to see, is it just a delay or is it a fixed problem? But this is one of the things that I have to kind of emphasize. I have to emphasize it to my own staff when we have an HD meeting. They're like, why didn't this patient show up? Send them to the adults. They're not a pediatric patient anymore. So I said, listen, what do you think is going to happen when we send them over to the adults? These are not patients that are, you might as well ask them, ask them to complete your taxes. It's just not, it's not their fault. It's part of the disease. It's part of the disease process. What we also know is that it's not necessarily the people with the worst CKD do the worst. So we'll just focus attention on them, the dialysis patients. There's only 1,000 patients in the country. Let's put all our resources there. It's not so much that, but it's the duration of CKD. That seems to be the driving force. So you can have mild CKD stage 2. It's the duration that you've had, right? So once again, even if you have CKD 2 or 3 as an 18-year-old, you're not always have the same neurocognitive development as an 18-year-old. It has a subtle but persistent effect on the process. So part of this has to, it's this chicken and egg. What causes it? Does CKD cause the neurodevelopmental problems, or whatever caused the CKD, also causes neurodevelopment? We don't have the answer to that. We are slowly getting some answers. I will tell you, when we look at this congenital abnormalities of kidney and urinary tract, the most common cause of CKD in patients, there's a clear link between KCUT and genomic disorders. That if we look at patients with KCUT, about 10% of them we can just recognize off the bat, they have some genetic defect, a problem. If we look more carefully and we look at just deletions or duplications in the genome, we find another 10% have this problem. And we recognize that these genomic defects come with some neurocognitive problems as well. And you can just see here that, when they look at the CKID cohort, which I've mentioned before, compared to control, there's a much higher, and this is copy variation. I'm not going to get into the genetics here, but there's a much higher in this group of patients who have, chronic kidney disease for whatever reason. And then, once again, you show that even if you have the genomic, if I know you have a genomic disorder within that CKID group, you also are more likely to have more severe neurocognitive development. So I throw this up to say, hey, this is maybe it's not necessarily CKD itself that's causing problems, but the genomic problem that led to the K-cut, that led to the CKD, also led to neurocognitive problems. And then finally, I'll say, well, there's nothing you can do. That's not exactly true, because when we start to really look careful at these patients with neurocognitive dysfunction, we find we don't have any cause and effect yet, but we have some associations with targets that we can address. So one of the examples is blood pressure control. That when we look at the CKID database, that we recognize, and the patients that have undergone ambulatory blood pressure monitoring, and we look closely at them, that this increased diastolic load and diastolic nocturnal dipping, that is at night, when we look at what their diastolic blood pressures is, that seems to be independently associated with impairments in neurocognitive performance. We're not so sure why that happens, but we could also say, hey, maybe this is due to hypertension, that hypertension itself is causing target organ damage to the brains of these young individuals. So it's not just as simple as me saying, well, you're going to have neurocognitive problems because you have CKD. There might be some modifiable risk factors that I need to pay attention to. Okay, so I kind of went off target there for a little while, but I really wanted to bring that up. So and I think out there, one of the things I think that really rings true is that when you transition to an adult hemodialysis unit, can you imagine what that's like for a teenager, right? First of all, you're going from care where the staffing is 1 to 2, right, as far as nursing, to 1 to 10 or 1 to 16, right? Think of yourself as a young person looking at the burden of CKD throughout the ages, right? And then add on top of that this idea that you might not have the same level, you might not be at the same place developmentally, neurocognitively, as an 18-year-old who suddenly developed end-stage renal disease. So these are the things that we need to work on, especially transitioning this patient. So in some senses, it's not fair to me call a press and go, hey, I have someone who's 21, they need adult dialysis now. It's not going to work. I know there's going to be a high failure rate there. I just don't yet have the tools to, and there's not like I have a transition dialysis unit out there that I can put the patients in, change the staffing a little bit, and it just doesn't work. So I'm going to summarize now to say that, obviously pediatric CKD is rare, but it comes with a very large burden of disease for the patients. And if you remember that one slide, that being on dialysis is like adding 50 years to your life, right? There's a large burden of disease there. The best data as far as challenges comes from the pediatric transplant field, and we recognize that transition in this age group, for whatever reason, whether it's neurocognitive problems, whether it's insurance problems, whether it's just being a teenager, right? This is a precarious time. So we've given this patient's been given a gift, and a lot of times they'll lose that gift just by simply transitioning them from pediatrics to adult. I personally believe that one of the huge barriers is finding providers, because a lot of these very rare diseases, cystinosis, X-linked hypophosphatemic rickets, anytime you have a rare disease, you can find specialists, but and then there's some states out there without a pediatric nephrologist, right? In the United States. So to expect an adult doctor to just pick up, fresh with it, it's not fair to everybody. It's not fair to the patient. It's not fair to the adult doctor, right? And then finally, the thing I want to remind you is that this idea that we've babied our patients, and that's contributing to the transition period. I want you to think of, I'm not saying that's not happening, but I want you to think of an alternative perspective, in that the reason we baby these patients is not because, I like babying my patients, and, it's not necessarily that, but I have to. That is, to be able to deliver care to these patients, I have to recognize that neurocognitively, I have to treat them differently than an adult. That in some senses, I do have to baby them. That if they don't show up for their appointment, I have to call them and find out why they didn't show up, as opposed to going, well, too bad, so sad, I have to do that. So I think that sort of ends my talk. I do apologize I don't have a great transition model for you, but I felt today the burden that I had was to kind of convey to you what are some of the challenges that we face on a day-to-day basis, and also on a national or even global perspective. Thank you very much. I did want to. This one of the things as I was doing research, I forgot. This is a great website. So if you're a pediatric provider, an adult provider, and you have a patient or you're working in the world of transition, this particular site, you just put your name and your address, and you're able to download sort of, I guess, a pamphlet of transition for the docs, the adult and pediatric docs, and also for the patients themselves. So there's a lot of work being done on transition. Maybe not necessarily in the field of CKD, but there's a lot of work out there.